Good evening. My name is Tina Robinson, and I'm a member of the Harbor Area Chapter of the Links Incorporated and chair of the Health and Human Services facet. I want to thank you for joining part 2 of our series, Leveling the Playing Field. Tonight's topic is on colorectal cancer awareness. Okay. Now let's move to an overview of the session. Okay. During this time, you will learn about the prevalence of African Americans, prevention, early detection, advocacy, and you'll also receive resources for additional information and assistance. Please focus on the screen here. Of note, everyone should be aware that this session is being recorded. Okay. Now I'd like to introduce our moderator for this evening, our very own president of the Harbor Area Chapter of the Links Incorporated, Dr. Valerie Green Amos.
Thank you so much, Tina. It is my pleasure not only to represent the Links Incorporated Harbor Area Chapter as the chapter president, but to moderate tonight's really exciting and dynamic series closure, focusing on the National Colorectal Cancer Awareness Month topic, specifically focusing on health inequities and healthcare disparities. The Links Incorporated prides ourselves in focusing on opportunities to share education, resources, and advocacy. And tonight, on behalf of the Health Equity Advocacy Links Initiative, which is a foundational supportive initiative that is in collaboration with the American Cancer Society, we are so pleased to bring you not just local, but national thought leaders, specifically around colorectal cancer, and not from anyone's perspective, from our perspective. It is an absolute pleasure for me this evening to actually have a panel of friends and colleagues. So I know you're going to really enjoy this session. It's not the topic perhaps that you might think, oh, Tuesday evening, I'm going to learn about colorectal cancer, but guess what? We're going to make it fun and fabulous. So we just hope that you will learn something and you will really participate in the opportunity to feel more empowered around your health, specifically for yourself, but also for our community. So you'll see here, there's amazing talent in this conversation. We're going to hear from Dr. Rhonda Luster, a renowned internist, Dr. Melanie Jackson, a gastroenterologist, Mrs. Darlise Blount Harrison, who's a health advocacy and a wellness coach, we'll call her. And then last but not least, the top Los Angeles colorectal surgeon, Dr. Zuri Morel, who happens to be my Morehouse brother. So we're going to have a great time this evening. We just hope again that you will use the information that's shared tonight through the Health Equity Advocacy Links Initiative to really foster your knowledge and understanding around the value and importance of colorectal screening. Now, as we start this evening's conversation, there are a few reminders that we're going to share with you. But in addition, we're going to really try to garner your understanding through some pre and post questions. The individuals this evening are actually participating in content to this knowledge check. So we're going to see how much you know about colorectal cancer screening. So here's our first knowledge check. So I think that we've had a little bit of time here to answer some questions and see how much knowledge you have around colorectal cancer. If you're familiar with the Harbor Area Chapter of the Links Incorporated, you know that we have done a myriad of webinars, specifically focusing on engaging our community during the COVID era, as we'll call it. Tonight's webinar slides are actually in blue, and I hope you know why. Blue represents colorectal cancer, and we want to make sure we're providing awareness. So many of the slides that you'll see this evening are in blue, not the typical link screen, but in blue, because we really want you to be aware that colorectal cancer is something that we can largely prevent, and through the awareness and education that we'll provide this evening, you will be empowered to be able to make the right choices to save your life and those of your loved ones, friends, and family. So right now we're going to hear from Dr. Rhonda Luster. Dr. Luster happens to come to us from our sister chapter, the Palos Verdes chapter of the Links Incorporated. So without further ado, I'd like to introduce Dr. Rhonda Luster. She graduated from UCLA undergraduate, UCLA Medical School, and UCLA residency. She has had a long and storied professional career, focusing mostly on managed care in underrepresented communities, but she also now has her own private company and she serves as an independent medical consultant. So we're going to have Dr. Luster talk about screening and prevention. Dr. Luster, I thank you and ask you to take it away.
Am I on mute? Can you hear me?
We can certainly hear you. Thank you, Dr. Luster.
Okay, thank you. Thank you, Dr. Green Amos, for that wonderful introduction. So what my perspective is going to be as a primary care physician is what we think about when we have patients come into us and need to have colorectal screening. So what we will go over tonight and on my section here is the different types of tests that are available and why you may choose one versus another. Just a little bit of background for you. Colorectal cancer is the third most commonly diagnosed cancer in the United States. Most colorectal cancer is diagnosed when patients have symptoms, and those symptoms are often a change in their bowel habits. They notice some rectal bleeding, or your primary care physician may notice that you're iron deficient for an unclear reason and starts a workup. In order to reduce the number of cases of colorectal cancer, we have to increase the utility of screening tests. So let's go into the types of screening tests that there are. These tests are often ordered by your primary care physician or your mid-levels. In order to advocate for yourself, you have to know what is available and what will work best for you and your lifestyle. Some patients feel that they haven't had symptoms, and for that reason, there's no need to go through the trouble of obtaining any type of screening. But know this, a positive fecal occult blood test, and I'm saying this slowly because I want you to really get this, a positive fecal occult blood test, also known as a stool card, has a higher predictive value of colon cancer than having any form of symptoms. So it is important that you get screening. Next. The screening tests. There are multiple screening tests that are available. Not all have the same ability to detect abnormalities. So we'll go through each one and we'll talk about its ability and whether or not this is an appropriate thing for your lifestyle. The first one is the fecal immunochemical test. These tests require one stool sampling. It doesn't require any discontinuation of your medications or avoidance of food. You can turn in the kit. When you collect the sample, you should turn in the kit immediately within 24 hours for this collection to be good. It's very easy. It's no dietary or medications restrictions, as I previously said. You don't need any bowel prep, and you don't need any time off work. This fecal immunochemical test is more sensitive than the older fecal occult blood test. FIT testing is required yearly, however. Next. Now, the fecal occult blood test or Guaiac test, that's what FOBT stands for, This test identifies blood in the stool by turning a reagent paper blue. This one is also performed once a year. It does, on the other hand, requires some meal and dietary restrictions. You can't have red meat or vitamin C for 3 days prior to testing. As well, no anti-inflammatory medications for 3 to 7 days prior to testing. Your PCP in the past may have done a digital rectal exam, which means inserting their finger in your rectum to get some stool and apply it on one of these cards. We no longer do that because the simple activity of inserting your finger into the rectum can cause a bit of small micro tears, and those micro tears will bleed and give you a false positive result. The advantage, however, of this test, it's not invasive, you don't need any bowel prep, and you don't need any sedation. But what it's not good for, it's not good for detecting a cancer that might be present in the colon if the cancer is not bleeding. It's not good for detecting polyps, which can later become cancer and which often do not bleed. Overall, FIT is more effective than the fecal occult blood test. Okay, next. Now there's a newer FIT test, and you've probably seen this on TV. It's advertised quite a bit, Cologuard. So this particular fecal immunochemical test has another component to it where it looks for DNA, and it's looking for DNA that may be coming from a malignancy that is in the colon, but there's otherwise no symptoms. In this particular case, you have to submit a full sample of stools and send that in for testing. Testing here is every 1 to 3 years. So that's an advantage to reduce to 3 years. There's no dietary or meal restrictions. And if you're looking at if you're comparing the FIT versus the FIT DNA, which is Cologuard, and picking up colorectal cancer, the statistics show that Cologuard is more sensitive and will detect up to 92% of colon cancers, whereas the FIT will detect up to 74%. Now, the next step is colonoscopy, which is direct colon visualization and the advantages of this. Dr. Jackson obviously will get into more details, but from the primary care physician, this is what we're thinking. This procedure is performed clearly by a gastroenterologist using a flexible scope to look at the rectum, colon, and sometimes the end of the small bowel. Patients with average risk, meaning they have no personal or family history of colon cancer, colon polyps, or inflammatory bowel disease, are screened every 10 years. If a patient has a higher risk, meaning that you have like a first-degree relative, a parent, a brother, sister, personal history of colon polyps, or prior colon cancer, then screening is more frequent. The advantage of colonoscopy is the ability of any lesion or growth or abnormality can be biopsied or removed at the time of the colonoscopy. It does require a liquid diet, a forced diarrhea, and holding of certain medications prior to the procedure. In the US, however, you do get sedation. This is the gold standard procedure to look for precancerous and cancerous growths. Complications of colonoscopy procedures are possible. Sometimes there's perforation of the colon, bleeding, and infection, but these events are very rare. Thank you.
So thank you so much, Dr. Lester. Really appreciate your primary care perspective. At this time, we're going to hear from Dr. Melanie Jackson. So Dr. Melanie Jackson is a renowned gastroenterologist, one of few African-American women gastroenterologists. And she's going to talk to us today about colorectal cancer awareness and screening from the perspective of a GI doctor who does this work on a regular basis. Now, Dr. Lester and I have talked and known each other for many years for our career, but Dr. Jackson and I have known each other our entire lives. So I'm very excited to hear from her presenting professionally as a gastroenterologist. She's a native Philadelphian like Mrs. Harrison and myself. She is a graduate of the Philadelphia High School for Girls, Morgan State University, followed by Howard University School of Medicine. She did her residency and fellowship at Columbia University Presbyterian Hospital in New York City. And she has been in the Maryland community working and serving as a phenomenal gastroenterologist. She's a member of Delta Sigma Theta Sorority Incorporated and Jack and Jill of America Incorporated, Prince George's County chapter. So without further ado, I'd like to hear now the amazing, phenomenal Dr. Melanie Jackson.
Well, thank you for that introduction, and thank you so much for having me tonight. So yes, just to kind of give you my perspective, I'm a gastroenterologist, so I'm the one that actually performs the procedure, and we work pretty much very hand in hand with primary care physicians as well as the surgeon that you'll hear from later. So just to add to what was said earlier, colorectal cancer is the second leading cause of cancer death in men and women. So in your lifetime, I mean, 1 in 23 men and 1 in 25 women will have colorectal cancer. Now, this year, they estimate that it might be about 151,000 new cases and almost 53,000 deaths, but this has gone down. So compared to 2020, the number is like 153,000. Unfortunately, the numbers are going down in the population over 65, but the numbers of colorectal cancer are going up in the population under 50. All right, so the one thing about colorectal cancer, it is treatable, it is preventable, it is beatable. And if it's one of the few cancers, if it's caught in stage 1, even 2, 3, you will survive it. And so your 5-year survival rate, if it's early stages, 90%, unfortunately, if it is widespread, it's about 14%. There's unfortunately a higher incidence of colorectal cancer and lower survival rates in African Americans compared to Caucasians. Why is this? We suspect later stage of diagnosis, and basically because of what we're doing here. There's less awareness in colon cancer screening services. And African Americans have a 40% chance more of dying for colorectal cancer than whites. But colorectal cancer does increase with age and equal frequencies in men and women, and the median age is 66 years old. So what are the signs and symptoms? Dr. Luster already told us, but the main one, believe it or not, is no symptoms at all. There are patients that come in for a routine screening colonoscopy, and we do find colon cancers, unfortunately. So how do you get colorectal cancer? What makes someone susceptible to have this? There's risk factors that we'll talk about. There are modifiable and unmodifiable risk factors. So you cannot control, you're going to get older, and you're already born with your DNA, but you can control your diet and your physical activity. Your family history, very important. We tend to not talk about that, but it's really important if you can find out, did your mom, even grandparents, especially if they were younger than the age of 60, did they have colorectal cancer? So all colorectal cancers start from colon polyps. This is where they start. And we know this is an abnormal growth of tissue that is found in the colon. There are 2 types of polyps. You have benign and precancerous. And only a few of these polyps will actually progress to colorectal cancer. And this does occur slowly over 10 years. But again, this is where colon cancers start from. Precancerous polyps are usually found in individuals by the age of 50 and about 25 to 30%. By the time you're 70, 50% of patients can have colon polyps. So that means your first colonoscopy may be normal. It's important not to just, I got it at 50 and I'm 45 and I'm one and done. No. Because a lot of people will have maybe a normal one at 45, 55, and at 65, I may find a polyp. And your risk of colorectal cancer increases depending on the size of the polyp, how many polyps you have, and the type of precancerous tissue. But I'm going to say this twice. The removal of precancerous polyps prevents colorectal cancer. This is what colon polyps look like. This is what I see. I guess I'm not sure, to my left, it's more of a 5 millimeter polyp, maybe precancerous, maybe benign, very easy to remove. One in the middle, more advanced, This definitely, just looking at it, I can tell you it's got precancerous tissue. It looks about 1 centimeter. It's on a stalk. And then of course, the one to my right is a very advanced polyp / almost, mass. Sometimes these actually come back as just precancerous tissue, but usually when we see them this large, sometimes we have advanced endoscopists that can remove this, but a lot of times we will refer you to the surgeon to remove the entire section just because we can't get deep enough to get that all out. So most people, people believe, colorectal cancer occurs in 75% of patients that don't even have a risk factors, no family history. So everybody needs to get their colonoscopy. 15 to 20% of cases are related to family history, and there's a small percentage that are related to genetic conditions. So increased risk, like Dr. Lusser said earlier, older, prior history of colon cancer and polyps, if you have a family history, and if you have long-standing inflammatory bowel disease. And that's a special category of patients. And those are called ulcerative colitis and Crohn's colitis. And once you have been established, once you have so much the disease over 10 years, we then screen those patients either every 1 to 2 years when they get to a certain point. And then there are genetic conditions called FAP and Lynch syndrome. And that Lynch syndrome is starting to tie into breast cancer. There are now patients that have breast cancer that they are testing for Lynch syndrome, because what that means is it's multiple different generations with different types of cancer. So it can be colon, breast, ovarian, endometrial. So you might have an uncle with colon, an aunt that had endometrial, a grandparent that had breast, and then you have maybe a grandchild that had colon. So again, this goes to family history. And again, anyone that usually gets the diagnosis of breast cancer, they are now testing you for this, or endometrial cancer. These are the modifiable risk factors. So you can increase your risk if you can, obesity, red meat, alcohol excessively, but you can decrease your risk. Making sure you stay active, having a diet that's rich in fruits and vegetables, diet low in red meat. And believe it or not, I actually gave up red meat 2 years ago, and Darlise and Valerie can tell you I loved cheesesteaks. So now I've moved to chicken cheesesteaks. But there are also some studies that show that calcium, vitamin D, and other supplements like folate can help to reduce your risk of colorectal cancer and polyps. So we screen you based on your risk factors. You should talk this over with your primary care physician and know your family history if possible. The preferred choice of screening is a colonoscopy. It is now recommended that all Americans, a couple years ago, which is African Americans were 45 and everybody else was 50, all Americans, all adults, symptoms or not, should start their screening colonoscopy at the age of 45. And if normal, you get them done every 10 years. So what is a colonoscopy? It's done by a physician like myself, a gastroenterologist or a surgeon, and it's used for detecting and removing polyps. It is a flexible instrument because you actually have, believe it or not, about 4 feet of colon in it, 4 to 5 feet, depending on the person. You do have to do a bowel prep the day before, and that is the worst part of it. So you do have to do a clear liquid diet and drink a flushing solution that is going to clean you out. And as I like to tell my patient, it should look like lemonade by the time you're done. When you come in, you get sedation. You have to have a driver, but you don't feel or remember anything. It is not a painful procedure, and it's a moderate sedation. So you're still breathing on your own. We give you a little bit of oxygen just to supplement. And this is covered by Medicare and most insurance companies. This just to show you a picture of what a colonoscope looks like. And you can see it's not very big, and that's a quarter there. So it's not much bigger it's smaller than the diameter of a quarter. The next picture shows you what your colon looks like and how we go around. So if you look at the yellow line, that's where the colonoscopy, it goes all the way around. We used to do a test called flexible sigmoidoscopies. That's usually more limited to really doing some diagnostic procedures, but the recommendation now is to have a complete colonoscopy to look at the entire colon. So these are the screening strategies that Dr. Lusser talked about earlier, so I won't go into those. And these, again, talking about high-risk patients. If you have these syndromes, you should get screened in your teens, and you'll have annual exams in your 40s. And again, if you have a first-degree relative with colorectal cancer, especially under the age of 60, we like to start your colonoscopies at age 40 or 10 years before that person had colon cancer. So if your mother had colon cancer at 45, you need to be seeing us at 35. So again, if you have history of colon cancer, we work with the surgeons. We repeat your colonoscopy in 6 months, a year, and then every 3 to 5 years for the rest of your life. And again, your personal history of precancerous polyps increase your risk of colon cancer. So polyps are, if they're detected, If you have those less invasive tests that Dr. Luster talked about, and they are positive, then you will be referred to a physician like myself to have a colonoscopy. And if we see those polyps on the colonoscopy, they're removed. Now, unfortunately, we do see colorectal cancer. We do something called a tattoo. So we leave a landmark for our wonderful surgeons so they know exactly where to go. And then you go through staging and you're referred to a surgeon and a medical oncologist. And your treatment really depends on the extent of the disease. But also very important is to make sure that you get colonoscopies afterwards, because you're still at increased risk for having colon cancer, even if you had colon cancer once. So this is a picture showing what it looks like during my procedures. This is where we're taking a polyp out called a hot snare. And you can see it's completely removed and a little tiny burn there. And that polyp is no more. So primary prevention is the key. Have a sensible diet, vegetables, fruit, limit red meat, avoid obesity, regular exercise, consider supplements like multivitamins, calcium, folate, limit your alcohol intake, and participate in some type of regular screening, being the less invasive tests that were talked about earlier, or just coming straight in for the colonoscopy. And again, those tests, those less invasive, are for asymptomatic patients without family histories. If you have a family history or personal history of colon cancer or colon polyps, you should just be getting screening colonoscopies. And inflammatory bowel disease, you should just be having screening colonoscopies. And know your family history if possible, so we can determine if we need to see you earlier. Thank you.
Thank you so much, Dr. Jackson. So we've heard two amazing physicians, Dr. Lester talking about primary care and screening, Dr. Jackson actually digging into the colonoscopy, what it feels like is really the question, right? So we know that we have to do these things. We hope that we do these things on schedule, but the question is, what does it feel like? Well, we have someone who's going to share with you what it feels like. We have Mrs. Darlise Blount Harrison, also a native Philadelphian, a very dear friend of mine, happens to be a member of Delta Sigma Theta Sorority Incorporated and the Links Incorporated, Dallas, Texas chapter. Mrs. Harrison actually has spent her career as a broadcast journalist, a writer, and a health advocate. She has a very creative way of telling her stories, as always. But really, she shared with me her story around colon cancer screening. So I felt like this was a great opportunity for all of us to hear the advocate's perspective. Again, we have some phenomenal physicians, but the everyday patient, what does that feel like? Well, we're going to hear now from that person. Doctors, and advocate here, Mrs. Darlise Blount Harrison. Thank you, Darlise, for joining us this evening.
It is my absolute pleasure. Thank you so much, Dr. Green Amos. Thank you so much to the Links chapter for tackling this very pertinent topic. For most people, when they think of colonoscopies, you know, it's so the fear of, I don't want anything going up my butt. Oh, what it's going to be like, you know, you could think about that. But one thing that's so wonderful that this panel is doing is demystifying a lot of the fears you might have. I myself, I'm very proactive about my health. Number one, I value living. I want full quality of life. So I take steps to do pre-screenings to make sure everything is well. I'm blessed to have Val as a friend and line sister. I'm also blessed to have Melanie as a friend and soror. And one thing that Melanie is so passionate about, Dr. Jackson, is so passionate about is Black women, quality of health. And she also stressed that when you're 45, get your colonoscopy. About 5 years ago, I turned 45. So I reached out to my primary physician about getting a colonoscopy, and she thought it was a good idea. We just talked about things. I don't have personal family history of colon cancer. However, I do have other cancers in my family. So I just wanted to do things because I don't want to find out things on the back end, but just take proactive steps to tackle something in the forefront if need be. So my doctor was for it. When I went to make the appointment, they were like, make sure you talk to your insurance company. So even though it was recommended and suggested that Black women get it done at 45, their insurance company has their own set of rules. So I had to end up going back and forth with the insurance company about getting it done. And it's like, it's a procedure to get done. And I told them I wanted the insurance company to cover me at 45 with the same benefits I would get at 50 as an African-American woman, with our risk factors being higher. And I presented them with information. Long story short, went back and forth. I had to end up paying out of pocket. So even though now nationally that they're saying across the board it's 45, some insurance companies are still saying you have to be 50. And in order to get 100% covered. So if you're going to want to get this done and you're not sure if you have family history, but you just want to do it just to be proactive and you want it covered, talk to your insurance company, because most will not pay, unfortunately. They might do a deductible, but they're not going to do it. That shouldn't deter you. You can say that you're not sure of your family history, use that as an option. You can either wait till you're 50 or you can pay yourself. But just to move forward about what the colonoscopy was like, it was not painful. It's more painful to think about than really what it was. Dr. Jackson was phenomenal. She didn't do my procedure, but just as a friend, I was able to call her and she walked me through the liquid diet. It's anything clear. It's not just soup. She was like, eat lemon jello, eat lemon popsicle. So, it's more that you can do that, so you don't feel like, oh my gosh, I'm starving, where you do have some sustenance, as well as the liquid. The day of the procedure, people at the facility were extremely nice. It's a delicate thing, you're dealing with your body. People were very kind. I was sedated. I do not remember anything during the procedure. I just remember waking up feeling fine. So like she's saying, with the light sedation that you get, they're doing what they need to do to find out. And in all transparency, they told me they found a polyp that as they pulled it out, they were just able to take away. I was fine and I don't have to go back for 10 years. So for me, that's peace of mind. It's like, as a woman, as a mother, as a daughter, as a friend, as a wife, I want to be here and I want to do things that might seem uncomfortable, but have long-term effect and they are powerful and will prolong my life. So I'm glad I did it. I really advocate and suggest for people to do it. Partner with your doctor. Your doctor is your friend. Talk to them about concerns you might have. And as stated earlier, sometimes you don't have symptoms, so you don't know. So if you have family history, don't have family history, what do you do? I wanted to do the colonoscopy, like I said, for peace of mind. Right now, my husband's about to turn 50. So we're in the process of, okay, it's a few months different. If the insurance company doesn't pay, he's partnering with his doctor right now to figure out what are the next steps. So these are just things that you have to do, but it's like your health is paramount. Unfortunately, in our community, we hear about so many people who are dying from preventable things. So anything we can do to prolong our life, let's do it. And again, I want to thank you, Dr. Green Amos, for this powerful discussion, and doctors for presenting the information and really demystifying a lot of things where people might want to be afraid of doing something because it might be uncomfortable, it might be painful, but it's not painful, just uncomfortable, but it's very important. And the long-term effects speak for itself. So thank you.
Thank you so much. To hear from someone who's experienced it personally and has a passionate voice is really paramount for all of us. So I thank you so much for being willing and able to participate this evening. We're going to now pivot to hearing from the colorectal surgeon. So we've talked about screening. We've talked about a colonoscopy as an opportunity for screening as well, but through a visual opportunity. And now we're going to hear about treatment. As was mentioned previously, colorectal cancer, is largely preventable. But it's only preventable when we have the resources, the skill set, and the health information to pursue what's best for us. So we're going to hear from Dr. Zuri Morel at this time. Dr. Morel happens to be a Morehouse graduate, class of 1996, I believe. Also a phenomenal colorectal surgeon based here in Los Angeles, Los Alamitos and Beverly Hills. He happens to be has had the title of being the director of colorectal cancer for Cedars-Sinai here in Southern California. Dr. Morel actually completed his medical school training at UCLA School of Medicine, like Dr. Lester, did his residency at Harbor UCLA, followed by a fellowship, actually did 2 fellowships, one at UC Irvine or University of California, Irvine, and then the second at Cedars-Sinai. So we're so blessed to have his voice this evening to complement our knowledge around colorectal cancer. So Dr. Morel, you've got the floor. Thank you so much for joining us.
All right, thank you so much. And it really delighted me to see, especially what Ms. Harrison said about being her own healthcare advocate. And that's actually more of what I want to talk about today. I need to talk to you guys about explain this to me. How can we tell you that there's a cancer that will have 95,000 newly diagnosed patients for colon, about 50,000 newly diagnosed patients for rectal, and about 50,000 deaths every single year, yet I'm sitting here smiling? How can I tell you that that is what's happening? Yet I can tell you it's almost totally preventable, and if detected early, is totally curable. I want everybody to do me a big favor. I want you to unmute yourselves. I'm trying to see as many people as I can. And I need everybody to do me a favor. Unmute yourself. And I want everybody to say these words. I want you to say the words colon.
Colon.
Say the words rectum.
Rectum.
Now the hardest one, say the word anus.
Anus.
Say, I will not die from fear.
I will not die from fear.
And I will not die from embarrassment.
And I will not die from embarrassment.
Embarrassment.
And that is one of the major reasons us especially are having some of the data that we have, actually, that is why we're dying from this disease. That is part of it. And so once again, we're looking at, you noticed the other doctor showed the 2022 data. I like to show the 2017. I used to have 2013. So it's been the same for a long time. And I will say that one of the major administrative outcomes, and this is the first time I've seen this and many others have seen it, when we talk about Obamacare, incidents for African Americans have gone up every single year. We were the only ethnic group that had not had a leveling off of incidents until about 2 years ago. And that is almost directly because of Obamacare, because more people are getting screened. And that's important for people to know, because I'm a private practice physician, and you'll hear a lot of doctors say this or that, and a lot of private practice physicians say something negative a lot of times about Obamacare. But this was really crucial in helping us actually start to turn the tide of colorectal cancer. So you're going to hear a lot of what we're talking about. You're going to hear this multiple times, but I think it's really important because you will be able to articulate this to your family, and this will help everybody become their own healthcare advocate. And we'll talk more about that. So once again, what is colorectal cancer? So the colon itself, when I ask people, what's the purpose of the colon? Most people say to make poop. Okay, that's not the purpose of the colon. The colon's number one job is actually to reabsorb water and salt. And then the rectum's job is to hold stool until a socially appropriate time to, as my daughters like to sing in Frozen, let it go. That's the purpose of these organs. Now, colon cancer starts in the colon, rectal cancer starts in the rectum. And so cancer in and of itself is a growth of abnormal cells. I have a patient who actually, you guys may have seen some of these shirts. She has a shirt that says an expletive cancer, it's just stupid. And that's actually what it is. Cancer loses the ability to basically, cancer cells lose the ability to stop growing. So the reason I have fingers that are this long versus this long, the reason I'm 6'2" instead of 7 feet tall is because my cells knew when to stop growing. Cancer cells just keep growing. They actually outgrow their blood supply. They actually take all of the glucose and the energy and the nutrients in our body. And so they use all that to grow. And that is how actually people die from colorectal cancer. So once again, colorectal cancer starts in the colon and the rectum. Now, while we don't know the causes of most colorectal cancer, the power of this disease and the prevention of this disease comes from the fact that most of it is related to DNA changes from our lifestyle. Only about 8 to 10% of colorectal cancer is genetic. Okay, so that means that, and for some of you on the call who don't know, my mom used to like to say that if it was important, God gave us two. So basically we have two alleles and two basic genes that can help us either get cancer or not get cancer. So if you think about, you're born with, let's say you're born with a genetic predisposition, but then you still have this one good gene, okay? It's our environment. It's the things that we do to ourselves that we put in our bodies that actually affect whether or not this will also be affected, so that then we can't fight off changes that are happening and we get cancer. So you guys see here, we got a plate of ribs, and I'm not gonna lie, okay? I'm gonna tell you some of my own personal story, but I love ribs, okay? Even in the summertime, I love ribs. And This is something that, you know, I myself, and the reason I give a talk like this is that we're all the same. Like it's not a holier than thou at all. And it's important when you relate to patients that you know these things. But if I ate this all the time, I would get cancer. I'd be obese. I would not be as healthy as I think I am currently. The reason I show this though is that this is something that can be modified, that you have the power to modify so that, and we'll talk about other things you can do so that you can help prevent this disease. Now, who's at risk? So there's factors, once again, and a lot of this is dovetailing to what you've heard before, but I don't feel like you can ever hear this enough, because the more you hear it, the more it will be ingrained. Okay, so there's two factors that greatly influence the risk of developing colorectal cancer. Once again, there's factors you can do things about, and there's factors you can't do anything about. So in terms of age, over 90% of colorectal cancers are diagnosed in people over 50, but I have something important and a little scary to tell you. One of my subspecialties is basically cancer in young people. I deal with colorectal cancer in millennials, colorectal cancer in 40-year-olds and less. And guess what? In the last 5 years, there's been a 12-fold increase in the number of patients under the age of 50 getting colorectal cancer. So while it's still more patients over the age of 50 who get it, this is a huge jump. And we're seeing this because of what I like to call and I hope there's, you know, I know this is a very established organization or esteemed organization. My aunt is in this organization, so I hope I don't offend anybody, but fast food restaurants, things of that nature, obesity is one of the major causes of this. Processed food consumption is one of the major causes of this. And these are young people getting it. 3/4 of millennials will be obese by the age of 40 in America. 3/4, that's huge. 2 out of 3 in some states, 2 out of 3 children right now are obese. And that is one of the biggest risk factors for some of all of these cancers. But that's one of the reasons why age is becoming, why the age of patients getting colorectal cancer is becoming lower. And then you look at race. So African Americans are more likely than any other racial group to get colorectal cancer and to die from their disease. And something that's very important, and we'll talk about why that happens, because there's many reasons, but it's not just what we do, okay? A lot of times when things affect us more, it's because why can't you guys eat right? Why can't you do this, that, and the other? Well, it is multifactorial, and it is not all about us in terms of what we do to ourselves. It is about things that are done to us, and we'll talk about that. So gender does not really be, it's not a real major risk factor. For men, it's the rate of colorectal cancer is like 4.38. For women, it's like 4.32. So it's equal. Sometimes I get females who say, well, that's just a man's disease. And sometimes it's confused with prostate cancer, which is just a man's disease. And a lot of men are saying, well, don't just women get that? And that's not true. It's almost equal. And so when you look at African Americans, higher incidence, but I am happy to tell you that our incidence has finally leveled off. While this is not something this is something actually to be very happy about. We still do have an advanced age of presentation, and we have a decreased survival. Also, what's interesting is Korean Americans, the #1 cause of cancer-related death in Koreans, not even Korean Americans, is actually colorectal cancer. Now, this is important because it goes back to diet once again. Koreans eat a large amount of Golby beef, which is like barbecue beef. When we all go to Korean barbecue, things of that nature. And they're the only Asian population where smoking lung cancer isn't the #1 cause of death. So this shows you the importance of diet in terms of this disease. Now, being African American, okay, this is something that I think is very important. You know, our stereotype that we are aggressive and you know, we're more argumentative is probably one of the, in the medical setting, is probably one of the most false stereotypes that there is. I remember when I first started practicing, I would go into the room, and I'm at Cedars-Sinai, so I have a lot of Jewish patients because I deal a lot with Crohn's disease, ulcerative colitis, which was really high in the Jewish population. But guess what? The highest population that it's increasing in is African Americans and Hispanics. But for our population, nobody even thought that those diseases existed. But anyway, I remember I walked into a room and I would talk to the patients, my Caucasian patients, and they would have articles and they would question me and say, what about this? What about that? And I remember at first I used to leave the room and I would say, well, is it because I was young? I didn't have all these gray hairs back then, but I'm like, is it because I'm young? It's because I'm Black? Like, are people questioning me? Because I would go to my Black patients and I would say, you know, do this is what I think. And my patients would say, yes. Okay. Now, Caucasian doctors, other doctors, and doctors in general, we love patients like that, right? We love a patient where we go in, we say what we think you should do, and you just say, okay. But, and you know, in this day and age, we get pulled in so many directions. We have to deal with healthcare systems. We have to deal with insurance companies. We deal with all of this. And so, yeah, we love a patient like that. But guess what? That's a me problem. That's a doctor problem. That's not a you problem. Those other patients, Caucasian patients, weren't arguing with me, but they were just, had been taught, and they had to talk to their doctors, to be teamed with their doctors, to be prepared for appointments, things of that nature. I was raised by two parents who were very educated, but I was also raised, things like if you have to ask, you can't afford it. If you, when you go to the doctors, you just listen, things like that. And I think that that's something that I really I take to my African-American patients, to my community, about being your own healthcare advocate. What does that mean? That doesn't necessarily mean going in and arguing with docs, but it means being prepared for your appointments, knowing what you want to get out of your appointment. I tell some of my patients that there are some random studies that actually show that if you walk into a doctor's office and you sit down and you unfold a blank piece of paper, okay, you just sit down, the doctor will sit down with you and you'll have more time to spend, okay? Now, this is harder. I am a private practice. I work with Cedars. I'm out of network. And the reason I'm out of network with insurance companies, except for Medicare, is because obviously I like to talk. And so I have the luxury of being able to spend a lot of time with my patients. Not all of us have that. If you have an HMO, for instance, you have certain time constraints. But once again, that is a us problem as a physician. I always tell patients that, you have your questions, and if the doctor's too busy to answer all of them, you just make sure you set another time, and so that way you can get your questions answered. But this is very important. Now I'm going to tell you why this is important, and my GI colleague will agree. So for African Americans, the age of colonoscopy has been 45 for about 9 years, okay? African Americans, one of the reasons we have the latest stage of presentation, one of the reasons we have a higher incidence is because there's study after study after study when you look at healthcare disparities. And this is something that Nicole Mitchell and I are working on at Cedars, show that when an African American leaves an office, they are offered colonoscopies a lot less, and they are often offered these less than ideal tests, which is the FOBT, the FIT testing, and Kaiser even has a big push for these Cologuard tests, which I'll talk to you guys about soon. But the bottom line is that we're not offered these tests. And so the study came out where they looked at GI doctors. This was 5 years after they made the recommendation about African Americans getting a colonoscopy at age 45. 5 years later, they did a survey of GI docs at one of their major GI conventions, and they found that one of the questions was, when should African Americans get screened? They found that only 20% of GI doctors knew that African Americans were supposed to get a colonoscopy or screened at age 45. And of that percentage, 90% of those were Black GI doctors. So what does that tell you? This is something that and if you're a patient, you would not necessarily know that unless you were kind of educated about this. And this is why, I would give this talk to you 100 times, because this is how important it is. It's not that often, doctors, there's some big conspiracy like all doctors are racist, but we all have inherent biases. And the problem is, when you're a physician, the biases kill Black people. Your biases kill Latino people. And part of that bias is, number two, is that there is still this fear of us or disagreeing with them. When an African-American patient, especially a male, when I say that you need a colonoscopy, now about 90, maybe 70% of men will say, "Doc, I don't want you sticking anything in my butt." And I say, "Well, do you love your wife?" Right? And they're like, "Well, what do you mean?" "Yeah, I love my wife, but if I get cancer, she'll be okay." But then I said, "Do you love your kids?" And they say, "Well, yeah, I love my kids." I said, "Well, do you know that if I do your colonoscopy now at the appropriate age, and I find a polyp or I find cancer, then your children would qualify for insurance paid colonoscopy at a younger age." Almost universally, when I say that, patients will get their colonoscopy. Now, the reason that colonoscopies are the best test is that the point of a colonoscopy is not to prevent cancer. I tell patients that all the time. The point of a colonoscopy is not to find cancer, it's to prevent it. It's literally the only test a man could have, and one of two tests that a woman can have that actually prevents cancer. My mother died of breast cancer a month before I graduated med school. Okay, she had her mammogram, she had her CT scans to discover brain mets. She had her x-rays to discover bone mets. She had all these tests just to discover cancer, okay? Now, colonoscopies prevent cancer because almost 95%, unless you're dealing with exotic melanoma of the colon, starts as polyps. And guess what? You take the polyp out while you're doing the colonoscopy. So this is incredibly important because it prevents it. Just like women, you go and get your pap smears, right? Pap smears are looking for changes in the cervix, and you actually remove those cells that have changed before it becomes cervical cancer. And that's how you have to think about it. And so it's very, very important that I tell patients all the time, like the primary care doc was saying, your primary care doc, if you're Black, does not necessarily have to be Black, but you need to have the kind of relationship with them that if they say that you need something and they say that, for instance, you need a colonoscopy and you say, no, doc, I don't want that. They need to be able to talk to you and come together. And I don't like to use the word convince, but explain to you why it's important and go from there. So a lot of times if a Black male says to a white doctor, oh, I don't want that sticking in my butt, the white doctor's like, oh, okay, here, have this fit test. Oh, here, do this Cologuard. As opposed to trying to talk through why this particular test is important. And so that to me is some more important than anything we're talking about now, is that your primary care doc is really the key to your life, okay? And really that means, and it's hard. The reason I'm not a primary care doc is to be a good one, you have to know way too much, okay? I like to focus on 3 things, and we already said it: colon, rectum, anus. That's me, okay? But you have to have confidence in your doc, but you have to have that relationship where you can work together, okay? And that's so, so important. That's very important. Now, other risk factors other than your ethnicity. Oh, one other thing that I think is really important. So worldwide, African Americans have the highest rate of colorectal cancer. And you guys know that there's barely anything that differentiates African American from a Caucasian. And if you look at the lowest rates of colorectal cancer in the world, I go to Uganda. Unfortunately, I go every 2 years. We haven't been able to go because of COVID. But when I go to Uganda, when I go to Nigeria, do you know what I do not operate on? Colorectal cancer. So colorectal cancer in those areas are some of the lowest in the world, okay? And even in India, some of the lowest in the world. Now, how can I be African American and have the highest rate in the world? And then you have Africans with the lowest rate of in the world. So this is why I'm so positive about the long-term outcome of this disease, is because it can totally be prevented. So in Africa, in Uganda especially, and Nigeria, number one is you don't eat hardly any red meat. And I hate to tell you, red meat is lamb, beef, and pork. Pork is not the other white meat, okay? Pork is also a red meat. Now, the way we break down food, right? We put it in our mouth, we masticate, chew it up, it goes down our esophagus, goes to our stomach. Our stomach is what breaks it down. It then goes to our small intestine. All absorption, like 98% of absorption, occurs in the small intestine. So it goes from the stomach to the 3 parts of the small intestine, which is the duodenum, jejunum, ileum. Once it gets to the ileum, it then goes into God's organ known as the colon, okay? So once again, when it goes into the colon, that's pretty much just liquid and some waste. The colon then reabsorbs the water, and once again, the stool is left over. Well, diets that are high in red meat, number one is we break red meat down into something called a nitrosamine. So a nitrosamine is something called a pro-carcinogen, it's pro-cancer, which means that if you put enough nitrosamine on intestinal tissue, eventually you will get a growth there that can become cancer, okay? That's why it's very important. Number 2 is diets high in red meat can make you constipated and slow that track down. Something else that they do, and actually it's really interesting, if you eat meat in Africa, I remember when I went on my first trip, that meat is so fresh, it's not that good. Like the reason we like red meat is because of salt, preservatives, all those things. When you eat fresh red meat, it's not that good. And one of the other things I want to say is I don't care if it's organic, I don't care if you got free range, I don't care if you lock your cattle in a can. It is still going to cause cancer if you eat enough. I eat red meat about maybe once every 2 months. In the summer, maybe it's once a month, but I really try to reduce that because that is something that can really lead to colorectal cancer. Now, something else they do in Uganda is fiber. They eat so much fiber that it is, it's amazing. I love surgical history. I love it for 2 reasons. Well, one reason is because it's really needs some of the experiments that they used to do. But I think it's important for us, especially knowing our history, knowing our African-American history, all of these discoveries, and as sickening as some of these, as good as some of these surgeries are now, as good as some of the things we do now, a lot of these were practiced on slaves. And so every day, the medical field should be thanking us for the bodies that we gave in order for us to know all of these advances, okay? So I'm really into surgical history. Number one is to show people why a lot of us don't trust the medical field in and of itself, but also to learn about how strong we were as a people, to actually have given so much in order for, for society to grow, whether we wanted to or not. And so fiber is so important. I think as a doctor, we always tell people to eat fiber, but we don't tell why. So there was an Irish doctor who was on a British ship, and Uganda was a British territory. And so this guy named was Paul Burkitt. He's responsible for Burkitt's lymphoma, and he's also the first person to put together, or the first person that is recorded to put together the diet and diseases. So I like to say I've published a lot, I do a lot of research, but this person was more dedicated to research than anybody I've ever read about. He basically he would collect the stool of Ugandans. He had the Ugandans poop in a bag, and he would weigh the stool. And he found that Ugandans made about 380 grams of a soft stool every 3 days. He then took the British sailors and had them collect stool. And he realized that the British sailors would make 100 grams of a hard stool every 7 days. And he started looking at the diet. The Ugandans eat so much fiber. They eat something called posha, which is a lot of beans and grains, okay? And they barely eat red meat. And part of the reason that they have so much, that they make so much soft stool is the fact that their colonic transit time is very, very fast. Now, fiber is important because it helps to increase or decrease the time from the time waste gets into your colon to the time you expel it, okay? And so I love to say that a quick and dirty way, and I do mean that pun literally, a quick and dirty way to see what your colonic transit time is if you eat a plate of beets, okay? And you wait and you finally have a bowel movement and you look at the toilet and you feel like you need to call somebody like me because you think you're bleeding, then you know what your colonic transit time is. And actually that's more of a proxy for your overall transit time, okay? It should be about 24 to 36 hours from the time you eat a plate of beets to the time you think you're having a bloody bowel movement, okay? That is something, that's how you know your machine, your engine is running at its optimal rate. And once again, it helps to decrease the time that carcinogens, that waste, are in your colon to the time you expel it, okay? And that's something that's very important because no matter what we eat, even if we eat, even vegetables in this country, still has a risk. There's still some carcinogens associated with it, okay? And so that's why it's really important to fine tune that machine and really know, number one, what you're putting in your body, and number one, what you're not putting in. What I tell patients all the time is that it's hard because, ground beef is cheap. Ground beef is very cheap. And I know people who eat it every day. But if you eat it, if you eat it 5 days a week and you go to 2 days a week, start making these minor changes, that this can definitely help you. But more importantly, if you're a parent, if you're a grandparent, this is what shows your children and your grandchildren how to eat right. I always say that the most important people, when I give this talk, if you're over the age of 70, unfortunately, it's not you, it's your family members, because you can be the one to help change the paradigm for generations. That's what's so important. That's what I tell men about getting their colonoscopies. You can save your generation. And one of the quick stories I'll tell, just like the woman who spoke before me, is my dad. My dad is, I'll leave the medical system out of it. But anyway, he was 50 and I was a resident. I'm like, Dad, oh no, I was a med student. I was like, Dad, you need to get your colonoscopy. And he goes and he's like, all right, I'll do it. And I never forget, he's driving home, he drives back into the garage and he's walking like this. And he looks at me and he goes, I can't believe you do this for a living. I'm like, what, Dad? He goes, I just had one of those scopes and this is horrible. I'm like, well, Dad, I saw you drive yourself home. He's like, yes. I said, and you're walking and you said you felt pain. Did it put you out? He goes, no. I said, Dad, you did not have a colonoscopy. My dad had a sigmoidoscopy. Now, a sigmoidoscopy is something that's done in the office, usually by primary care. It used to be done by sometimes even colorectal if we're looking for like some lower tract bleeding. And it looks at only the lower third of your colon. Now, this was an amazing test for decreasing colorectal cancer for all people except for African Americans. Now, most polyps used to occur in the distal part of the colon. So that's the sigmoid and the rectum. Well, what we know now is one of the reasons that this did not make a big impact in African Americans, even if they got a sigmoidoscopy, is that most of our colons are actually, most of our polyps are on the right side or the transverse colon. You cannot reach that with the sigmoidoscope. Now, at the particular time that my dad got this, I was doing a rotation at Kaiser. I talked to the GI doc there. I'm like, this is ridiculous. And I'm sorry, I did say Kaiser. I shouldn't have said that. But anyway, this is a true story. I talked to them and they did a colonoscopy on my dad. Now, my dad, literally about a 1/2 foot, 6 inches from where that sigmoid ended, my dad had 4 precancerous polyps. He had 4. Subsequent to that, and of course, I told him for many years, hey, Dad, I saved your life. Haha, I saved your life. I'm the best son ever. Okay. Subsequently, from the time that my dad had that colonoscopy, he's had a total of like 13 polyps. Okay. 13 polyps. Now, because I talked to my dad and we talk at the dinner table, and no matter what we say, you guys, the dinner table is the best time to talk about colorectal diseases. My dad is a very educated man, but I think it's the word rectum that grosses him out and disgusts many people and makes many people disgusted. But I'd still talk about that at the dinner table, because when is a better time to talk about colorectal cancer than when you're shoveling your face full of unhealthy food or even healthy food, right? So because my dad had his colonoscopy and had polyps, and I knew he had polyps, I got my colonoscopy. I'm 40, I turned 48 in November, so I just turned 47. I had my first colonoscopy when I was 42 because I knew my history. And I actually had a 2-centimeter precancerous polyp on my right side that would have 100% high-grade, not high-grade dysplasia, but it was moderate dysplasia. I would have had a cancer by the time I was 45, okay? It's not just whether or not you have a cancer history where you have to go 10 years earlier. It's if you have polyps also. And that's why it's very important to talk about it. I think we're getting better at discussing cancer, but we're not doing as good at discussing polyps. And so that's very, very important. Once again, being your own healthcare advocate is knowing the history. Secondly, we talk about in Africa, there's not a lot of obesity, okay? There's not a lot of obesity. And when you look at this country, one of the major risk factors for most cancers, except for blood-borne cancers, is obesity. From uterine, there's a pancreatic, there's a lot of cancers that are caused by obesity. Why? Is it just the act of being fat? No, it's because being obese actually is an inflammatory condition. What does that mean? That means that your body is constantly in a state of hypercortisol, which is a stress hormone, which actually your body spends so much time fighting the fat that it can't fight the precancers, the diseases that are in our body. And so that's why it is so important to try to fight obesity, no matter how you can do it, whether it's walking. Most of it is diet, though. The average weight loss of people when they stop eating red meat, for people who consume red meat more than, I believe the study was more than, I think 12 times a month, when they stop, if those people stop, you automatically are losing weight. It's pretty impressive. When you eat a lot of fiber, one of the biggest things that I'm a big proponent of is, and here, I'll show you guys this. So one of the big things I'm a proponent of, and I talk about it all the time, are berries, okay? Blackberries, blueberries, raspberries are God's berries, okay? What do I mean by that? I mean that they are full of fiber. So blueberries have about 5.3 cups of fiber per cup. Raspberries, blackberries have about 7.2 grams of fiber per cup. You're supposed to have 20 to 25 grams of fiber a day, okay? Every day, I have at least 2 cups of berries. I put that in a blender. I put in almond milk, because almond milk only has about 30 calories per cup. And I put in ice and I put in a little protein powder. I blend it. That's my breakfast. I walk out of the house with 14 grams of fiber. My children now, I have 2 amazing daughters, okay, 15 and 13. They make it for me. Sometimes they make it for themselves. And we do this as a family. If they were sitting here right now, they're so tired. They used to go with me to my talks. I used to try to do about 2 to 3 Black churches a month. And they're so tired of hearing about fiber, they could probably give this talk. But I'm telling you guys, fiber is amazing because it also has something in there called phytonutrients. There's a lot of science that's being developed looking at berries, because there's a lot of things that we think can fight cancer there. Now, this is great because when I do, sometimes I do talks in a lot of low income areas, and fresh berries are expensive, but berries maintain their nutritional value even if they're frozen. And that's what's so powerful about that to me. So when people think about fiber, sometimes they think about like Metamucil. prunes. Prunes are an amazing source of fiber, and actually they're not that bad, but prune juice is juice. Juice is not good because it's just sugar water. Now, something else that is very important is that processed food consumption. And so, I give a talk to kids. Have you guys seen kids, and probably, my kids are guilty of it when I'm not looking, that fire hot Cheetos where they eat Cheetos and, they're always licking their fingers because they got red powder on their fingers. If I ask you guys what a Cheeto is, what would you tell me? Is it a potato? Is it corn? If you read the back of a Cheeto is almost 95% chemicals made in a lab. And that's the biggest problem, I think, with America, with our diets, is that America, I love to say there's an infinite amount of food, but most of it's garbage, okay? And we eat so much processed food. This is the hard part. One of the biggest processed foods is bacon. Now, everybody loves bacon, okay? I have Muslim friends that like bacon. I got Jewish friends that like bacon. Everybody likes bacon, but bacon in and of itself is like one of the most processed foods. And so that's something that you really have to cut down on, okay? Now, something that's very important for us as African-Americans is vitamin D levels. So vitamin D is actually made, as most of you know, when the sun hits our skin. Well, guess what? We're protected from sun damage because of our melanin, but that also means African-Americans, we actually have to be in the sun longer than our Caucasian counterparts for our vitamin D to develop. Now, what's going on, especially with COVID, right? We're not going outside as much and we're working a lot indoors. And so it is really important to get outdoors or to even take vitamin D. I take about maybe 3 to 4 of those vitamin D gummies. You don't even have to have pills now. I take those every single day. Of note, vitamin D, if any of you have children, vitamin D deficiency is one of the #1 causes of depression in children, okay? So vitamin D is amazing. It actually helps to decrease your polyp formation. It helps with all of that, okay? And physical activity is really important because of endorphins and because it actually boosts our immune system. So I'm giving you a whole list. So I said there's 2 things you can't really do anything about, right? Race, age, but look at all the things we can do to decrease our risk of colon cancer. Now, we talked about the berries. People always ask me about probiotics. Well, probiotics are good. There's really no actual studies that show that they decrease cancer, but they can help decrease some of the symptoms that can be associated with cancer. Right, so they help decrease constipation, they help decrease irritable bowel syndrome, they help to stabilize patients with Crohn's disease. And this is important because if you're taking these and you have your system running optimally, when there's a change in any of this, it will make you and your doctor have a better conversation about, hey, now I need to get this test because this is a change in my bowel habits. And so once again, these are just the different benefits of probiotics. Now, we talked about this already, but the symptoms. The biggest issue with colorectal cancer, okay, is that change in bowel habits, which means that change in bowel habits means if you go every single day, clockwork, and all of a sudden you're going once every 5 days and it lasts longer than 2 months, you need to see your doctor because that's a change in bowel habits. Blood and stool. Now, we were talking about how the insurance companies, and I don't know, I'm going to say this, I know it's recorded, but sometimes you do what you have to do, okay? If you are 25 years old, and you say you have blood mixed in your stool, you're going to get a colonoscopy, okay? Sometimes you do what you have to do, but blood mixed in stool, you have to have a colonoscopy because it could be something higher up than hemorrhoids, which is rectal bleeding, okay? Most of the time I see patients that come in with rectal bleeding, bright red blood per rectum. That means the blood's on top of stool or drips in the toilet. Most of the time that's going to be hemorrhoids, but it's not all the time. And so when I see patients with the rectal bleeding, once again, most of it is not cancer. You still have to do a rectal exam. I look in to see if they have hemorrhoids. If they have hemorrhoids, I treat them. And guess what? If I treat them, they're not getting better over the course of 2 months, colonoscopy, because just because you have hemorrhoids does not mean you don't have a cancer, okay? So all of that is very, very important. Now, some of the other warning signs like abdominal pain, when that starts happening, it's kind of a little late in the game. But once again, that's why I'm in this field, because if you catch colorectal cancer early, okay, then you can still cure it, but you need somebody like me. You need a surgeon. And my whole point is that it should be done without the need for me. Like I should never have to do another colorectal surgery. Now, the reason I kind of am not a big fan, so I do a lot of outreach and I do go to do community clinics. And when I do that, because I can't just do colonoscopies on people, we do a fit test because it's better than nothing, okay? In terms of giving that to some of my patients without insurance, things of that nature. And then if it's positive, we try to find a place where they can get a colonoscopy. The real problems I have with fit tests, especially for if you're insured, you pay all this money for insurance. And the problem I have with the Cologuard test is that, once again, what's the point of a colonoscopy is to prevent cancer. Those tests are good at finding cancer. However, the Cologuard test and the FIT test are not good at finding polyps. And so the benefit is still that if you do the Cologuard every 3 years and you do the FIT test every year, if you do find it, then you'll find a cancer early, but that still means you need surgery. Surgery has complications. Surgery is, I do not, take it for granted. I love operating, but there's a lot of other things that I can do besides operating on a colon cancer. There's always hemorrhoids, there's always anal fissures, there's always diverticulitis. There's so many things, but cancer does not have to be one. And so I understand why these tests are out there because, a lot of times people will say, and I work with the American Red Cross, that you should give the patient the test that they will do. I disagree with that. Okay, you should do that, but that should only be after you spend enough time explaining why you think one test is better than the other. And a lot of times with us, it's you need a colonoscopy. Oh, doc, I don't want you to stick anything in my butt. Okay, well, take this, as opposed to having that conversation. And so that's why being your own patient advocate means knowing kind of what you need, doing the appropriate reading, being prepared for your doctor's appointment so that you and your doc could have this kind of relationship. And so it's very important. And really knowing your family history. Okay, so we kind of talked about this, preventing colorectal cancer. The reason I'm a big proponent of colonoscopies, and I do know that it's hard to get it done in some of the health systems, but when you approach it with data like we're talking about today, it does make it easier. It does make it definitely easier to do. And that's something that's important to know. Colonoscopy is good at finding polyps. The other tests are good at finding blood that could be associated with cancer. And so the power of the reason I do colorectal cancer surgery as opposed to pancreatic cancer surgery is colorectal is preventable. And also if you have to see somebody like me, it's curable, okay? Even if it's a stage 3 cancer, and we all know about our brother, Chad Boseman, who died, stage 3, you can still die from that. However, the chance of you living is above 60% now. And for metastatic colorectal cancer, it still has the highest survival rate of any cancer when it's metastatic. Patients, 14 to about now 30% of people are living. We look at like 5-year survival rates. We're getting new chemotherapy. We're getting new treatments every single day. And so it is important for us to realize that there are treatments out there. We can talk about that if you guys want to talk about more. There's robotic surgery, there's laparoscopic surgery, there's open surgery, there's all these different kinds of surgery. But one of the things I want to talk about are this slide right here. So these are some of the barriers, okay? People will say, I feel healthy, therefore I don't need cancer screening. Well, most individuals with colorectal cancer early, you don't show any symptoms. That's why we do screening. So screening test means there's no symptoms, there's no family history, but we're going to do this to make sure nothing exists, okay? If you have a family history of polyps, i.e. myself, if you have a family history of cancer, then that's out the door. And you go and you talk to your doctor and you get the test earlier. African Americans are not at high risk for colorectal cancer. Well, actually, we have the highest incidence and we're at the highest risk for colorectal cancer. I eat healthy, I'm a vegan, I won't develop cancer. Well, although it can reduce your risk, there's vegans that can still get colorectal cancer, okay? Now, a lot of them are often new vegans or they have a family history. I'm afraid of a colonoscopy. Now this one, I always, I'm torn because yes, you could be afraid of it, but once again, there's some patients, I give them all the data and they still want this test, so I can sleep at night knowing I did the best I could for them to have this test. Now, what's interesting is I've never had a patient, and I do get referred for patients because I do a lot of colonoscopies for positive Cologuard, and I think out of maybe 45 patients that got sent to me just for that, I did not find a cancer. Okay, about 10% I found a polyp. So, I think you really have to be follow the directions. I like what the primary care doc said about those FOBT cards. The reason I'm not a fan at all is that there's multiple things you have to stop before you do it. And good primary care doctors like her know that, but a lot of people don't know that. And, they end up having either false negatives or false positives. Now, if you are proactive, then colorectal cancer can be prevented and treated. And that's what I want to leave you with, you guys, is that this is something that is in our hands, mostly. It's in our hands. And even if you have colorectal cancer in your family, if you start getting screened earlier, we can prevent that. So that's why it's just so important. And I want to thank you for giving me time to speak. Thank you.
Thank you so much for that incredibly informative dialogue. So we are going to, unfortunately, we're out of time, and we were hoping to have some time for questions and answers. But what I will ask you to do is be mindful, put your information, if you have questions, put it in the chat. We'll be happy to follow up with you. We might have to do a part 2 at some point. But the idea is that we are really, really proud of the work that all of our colleagues that are on this panel are doing to advocate, to offer screening options, and to, again, provide the information necessary so that we can make choices that are really going to help us live and live better lives. So thank you so much, everyone, for participating with us this evening. This was brought to you on behalf of the Harbor Area Chapter of the Links Incorporated. We're based in Long Beach, California, but serve all of Southern Los Angeles County. We are really, really, really thrilled that we've had so many people join us this evening, not just locally, but across the country. We hope that you will tune in next time to hear more about the way that we as African Americans can really focus our attention on not only addressing myths, but trying to ensure that these health inequities, these health disparities no longer persist in our community. So thank you again for joining us. My name is Dr. Valerie Green Amos. I'm the president of the Links Incorporated Harbor Area Chapter. I want to thank the Palos Verdes Chapter for their participation this evening. I want to thank Dr. Luster, Dr. Jackson, Mrs. Harrison, and Dr. Morrell for an amazing, amazing conversation around the value and importance of colorectal screening and advocacy in the African American community. Thank you so much for joining us, and we hope you have not just a great night, but a great life. Thank you so much.